Good afternoon. I'm Catherine Santoro, Director of Policy and Development at the National Institute for Healthcare Management Foundation, and I'm very pleased to welcome you today to our webinar, More for the Money, Insurance Design Strategies that Drive Value. Rising premiums are on everyone's mind, and we all want more for our money, whether you're a consumer, an employer or insurer, a provider, or a government leader. So why are we more savvy consumers and shoppers for anything other than our health care, which is arguably one of the most important things we consume? Today we're joined by an excellent panel of expert speakers who will be sharing insurance design strategies to curb rising premiums and encourage consumers to shop for value when it comes to their health care. Before we begin, I want to quickly thank NIHCM's President and CEO, Nancy Chalkley, who helped guide the content of today's webinar, as well as my NIHCM colleagues Katie McDonald, Carolyn Myers, Amanda Parker, and Claire Rudolph, who provided assistance with communications and logistics. You can find biographical information for all of our speakers, along with today's agenda and copies of their slides on NIHCM's website. I'm now pleased to introduce our first speakers, Dr. Sanjay Saxena, a partner in BCG's healthcare practice with 15 years of healthcare consulting and industry experience, along with his colleague Nate Holobinko, a principal in BCG's New York office, where he's a member of the healthcare payer and insurance strategy practice areas. Sanjay and Nate are joining us today to kick off our discussion by sharing their research and perspective on designing consumer-centric provider networks.
Catherine, thank you very much, and thank you everyone for joining today. Just on slide 2 here, wanted to spend just a minute talking about some of the things that BCG has been doing as a result of healthcare reform and our commitment to enabling a value-based transformation of the healthcare system. Been making a number of significant investments around how the market will evolve, some of the new care models, and as we talk about today, some of our work with regard to new payment models, network designs, and collaborations to help support that. So as it relates to today's discussion on narrow, skinny, tiered networks, what's interesting here is you'll see that there has been an exponential growth in the interest around this topic. The number of media references alone since in the last 3 years has grown substantially, with nearly 1,000 references to the idea of narrow networks since ACA. You compare that to a level in 2009 where barely were we at 50, and you can see that the narrow network topic has really become important once again. Not surprisingly, there's a combination of support and skepticism for narrow networks. On the one hand, employers, benefit consultants, health plans have all been actively promoting the idea as a way of ensuring that consumers achieve greater value for their healthcare dollars spent. More importantly, they're also introducing new plan designs and transparency tools to help enable the use of narrow networks. On the other side, you have physicians, hospitals, health systems, consumer groups, all of whom have been raising concerns about issues with regard to access to care and quality that may result from narrow network designs. Narrow networks, for everyone who's been through the various transitions in our healthcare system over the last several decades, are not a new idea. They've been around certainly from the 90s with managed care, and various efforts have occurred on both coasts to try and introduce narrow networks, tiered networks, skinny networks, and other various names, all designed to try and limit or focus access to certain providers. And what we found in our research is that almost uniformly, every approach to narrow network development has looked as described here on the slide. Payers start with an existing list of providers that they have in their network. They look for criteria to try and determine which ones should be included in the narrow network. And not surprisingly, cost ends up becoming a very important factor, but also quality measures are also used. One of the challenges that comes up repeatedly is a lack of appropriate measures beyond some traditional process metrics that allow for true quality to be used as a screening criteria. There may not be adequate metrics, or in other instances, the sample size around certain metrics may be limiting. Once the network's been tiered, then traditional geographic access parameters are used to ensure that there are enough providers in a particular market, and there emerges the narrow network design. From this point onward, contract discussions occur and there are employer feedback, and ultimately you end up with the resulting narrow network design. It's not surprising when you think of that approach why consumers have historically not adopted narrow networks. Firstly, the cost-centric focus, while not the only measure, results in a network that's not necessarily the most consumer-centric in design. Secondly, the benefit designs oftentimes are not aligned with some of the medical management processes that underpin this. And finally, provider backlash, regulatory constraints, and employers who, while in the beginning are supportive of the narrow network construct, ultimately pull out, all make the implementation of narrow networks challenging. So what have we found that is helpful as we think about designing narrow networks for the future? And we'll share some of this, my colleague Nate Holubinko in a minute, on the work we've done to develop narrow networks that we believe will work in the future. The first and foremost parameter is we believe that narrow networks need to be designed around what is desirable to consumers. It's not enough to start with what are the most efficient metrics, what are the costs of the networks. We need to start with what is it that consumers are looking for and what are they willing to trade off as part of their network design. The second important parameter is that medical management processes we have in place need to think about the consumer experience. So, for instance, if we are to move to a narrow network, do narrow networks then come with appropriate improvements in the consumer experience such that prior authorizations, limits on certain elements, co-pays, other structural benefit design elements help reinforce the use of the narrow network and actually make the narrow network experience a more desirable and superior one as opposed to the broad network approach. And then finally, that there is a broad set of support from both individuals and employers for the narrowing construct. And here again, the consumer-centric component becomes critical. Our research has shown that if the employers and employees understand that the networks were designed around their preferences, there's actually a willingness and a desire to support the narrow network construct as it moves forward.
Great. And picking up there, Sanjay, it's nice to be speaking with everyone today. You know, one of the things that we picked up in our approach as we started to look at this topic is to think about the quality of the research that would need to go into this and to start to define the structures that Sanjay was speaking about on the last page. And one of the things that I'm sure is not unfamiliar to anyone on this call is that as an industry, healthcare has been far from consumer-centric, and the types of research methods and approaches that we've used in some of our designs in the past reflect that. And as we endeavored to go down this path, one of the things that we wanted to do was make sure that we were bringing some of the best practices from other industries, particularly the consumer packaged good industry that's been doing this for 30 years with great success, and to bring some of those practices to the table. And as we found when we went down this path, really the quality of the outputs that you get from the exercise are highly correlated to the qualities of the research that you put into it. Before we started to do this ourselves, we sampled what was available both in the industry and marketplace from a common standpoint, and found that a lot of the research that had been done to date kind of scratched the surface in a superficial way in terms of getting at what consumers were looking at. And similarly, even when we started to go down the path ourselves, some of the initial passes that we took at the effort yielded some pretty questionable findings from consumers when we asked them point-blank questions such as, do you like a narrow network, or what would it take for you to switch to a narrow network? Inevitably, when asking the questions in these ways, we got fairly simplistic answers back from consumers that didn't necessarily reflect the way that they actually behaved when they got out into the marketplace. So borrowing back to those consumer research techniques, one of the things that we found was particularly critical was to augment the consumer focus groups, which can be helpful at a high level with conjoint research, with maximum differential research, and then with actual shopping simulator techniques to make sure that consumers are actually behaving in a way that reflects the answers that they're giving. And aside from just understanding their general likes and dislikes, you can actually understand the quantitative implications of the decisions that they're making. So with that, what we did was, over the past several years, we've worked with a series of clients in the healthcare space to help them go down this path. In doing so, we developed a much deeper analysis approach than what had previously been done. So in order to get the granularity that we needed, we typically designed research surveys with very high N sizes, so very high numbers of consumers in the panel, so that we could do deep dives on what they were telling us. Most folks, I'm sure, are aware on this call, and in healthcare, it's not just important to understand what consumers want, but also to understand how those consumers segment, particularly in terms of their utilization of the healthcare system. So matching the right type of profiling criteria, as well as the right type of segmentation criteria up front to understand what type of respondents had what type of health conditions, what was their typical utilization profile before going into the survey, also helping anchor our outcomes. But lastly, one of the things that was most important for us, given that the core of this was really to dive deeper on what consumers wanted in terms of their networks and hospitals, was actually to ask the consumer's point of view in terms of what they thought of those hospitals. A lot of the research that had previously been done focused on, useful but commonly available metrics such as HEDIS or STARS outcomes that typically have more of a industry insider or B2B context to them. And instead, when we went down the course of doing our research, we actually asked consumers about specific surveys and asked them to tell us, both in their own words and in terms of what criteria they consider hospitals and primary care physicians to be important or valuable in terms of their care delivery experience and their insurance products. So as we went down the path and did a number of these projects for different clients, some of the results that came out were not particularly surprising, but a lot of these results are actually fairly interesting and even iconoclastic compared to what most of us think about when we think about the network guidelines or the classic rules of the last 20 years. Most interesting is that, whereas we discussed in the previous superficial surveys, it took a lot to get consumers to switch to a narrow network, or consumers at a high level had very bad opinions about narrow networks. When we actually got into specific combinations of narrow networks and specific offerings, we found that consumers could really wrap their brains around the topic and were very readily able to switch to a narrow network in exchange for a price discount. And particularly with the consumer as opposed to an employer audience, as much as 45% of the decision is based on price, and they're very ready to make that trade-off. Interestingly here, another factor that we saw that was surprising even to us was that consumers were far more willing to trade off a PCP than they were to trade off a hospital system. And particularly as we started to get closer to ACA implementation and consumers got savvier thinking about their costs, that factor became even more in the forefront. However, just in contrast to that last point, while most consumers, you could say that consumers in aggregate are a very price-sensitive group, there is a subset, about 30% of consumers, that actually buy insurance almost like a snob bid. And regardless of the specific inclusions in the network, they basically saw a low-priced product as equivalent to low quality, and basically showed an inverse utility or an inverse preference for that product. Getting into some of the things we saw around specific hospital inclusions and specific health system inclusions, some of the ways that we in the industry typically think about them are not what consumers think about. As example, safety net systems are not always necessarily a bad thing to consumers. Some of them, particularly in the exchange markets, are held in very high prestige and are seen alongside some of the bigger name academic medical institutions. And then lastly, probably less surprising to folks, is that many of the services that, particularly in the large group market, have become critical or must-have, such as medical management, wellness, gym membership, consumers don't really think about these things in the context of their insurance world. And while they don't mind having them there, they're really not willing to pay anything or trade off anything for them. So diving into a specific example on page 10, one of the things that was most notable to us as we get back to this concept of broad versus narrow is that when you take the word narrow off the table and you actually show consumers specific combinations of hospitals and specific facilities in their area, what consumers actually told us, and you can see by the relative utility here, is it's really not a question of breadth in their mind. Breadth does not equate to quality. It does not equate to price. What people were actually willing to pay the most for was a focused network with a single excellent hospital system, again, excellent as defined by the consumer's mouth, not by a third-party rating, such that they were guaranteed or felt comfortable that they had that excellent system to be able to go to. You can see here that the combinations of good and average hospitals ranked much lower on the relative utility scale. And even more interesting is that when you take that excellent system to add other good systems to it, it actually pulls the utility of that product down for the consumer, again, preferring the more focused but guaranteed higher quality product. Another interesting deep dive one that's made the news a lot, particularly if folks think about what happened in the Seattle market with some of the controversy over the inclusion of the Children's Hospital there. It's kind of vernacular in the industry that children's hospitals have to be in network, and it's one of the most important things when people buy their products. But again, what we found is that when you actually dive in and ask people to define in their own world what are the most important hospital systems or health systems, for many folks, having a dedicated children's hospital doesn't necessarily make the cut. They would rather have a single excellent system that they know and keep in high esteem, as opposed to necessarily having a system that's dedicated for children's services alone. And we even deep dove on this topic and found that as you consider both singles and family, while families do consider the children's hospital more important, it doesn't change the overall dynamic, which is that a preponderance or a plurality of the respondents really don't see it as a must-have, and again would prefer to have that single excellent system in their network.
So in conclusion, several takeaways from our research. I think the first one is important around why historically efforts to implement narrow networks haven't been successful. And I think the key takeaway for us is that they weren't ever designed around consumers. And so consumer centricity and really understanding how consumers think about network trade-offs is most critical. The second thing we'd say is that while we've seen narrow networks as part of some of the first generation exchange product offerings, most of them are again designed with a focus on achieving a lower premium. Going forward, however, we do believe that there's an opportunity for the industry to use networks as a means of innovation and redesigning themselves around the attributes that consumers value in their providers. So not only to use them as a vehicle for driving greater cost efficiency, lower premiums, but in fact to increase the satisfaction that consumers have with their products and network offering. The fourth one, which Nate highlighted some of the elements of our research findings, is that there are a number of things that over the last several decades we've built up as long-standing truisms as an industry, that branded is better, that you have to have an academic system in there in order for anyone to buy the product, that pediatric or children's hospitals must be there. All of those elements need to be suspended for a moment as one goes through the research in a particular market. While some of those elements may be true in certain geographies, what's interesting is that we found significant differences in consumer preferences depending upon setting and geography, and those will be important as one thinks about future network design. And then the last thing we'd say in conclusion is that we are at a point where there's an opportunity for our industry to transition to a new paradigm, where firstly, price is a meaningful differentiator for the majority of consumers. But at the same time, that we start thinking about products and networks that actually have fewer providers, but actually the ones that are highly valued by consumers as more powerful. Thank you.
Sanjay and Nate touched on different types of network strategies, focusing in on the narrow networks, and our next two speakers are going to delve in more deeply on tiered networks from the health plan, provider, and consumer perspectives. First, we'll hear from Dana Safran, Senior Vice President for Performance Measurement and Improvement at Blue Cross Blue Shield of Massachusetts. In this role, she leads the company's initiatives to measure and improve healthcare quality, safety, and outcomes. And today, Dana is going to be sharing their experience with tiered networks to successfully engage both members and providers while improving cost and quality. Dana?
Thanks, Catherine. And I'm very happy to be with you all this afternoon, and I will take the next 15 minutes or so to really address three aspects of this topic. First, how do tiered networks and our member-facing efforts fit into a portfolio of strategies to manage both quality and affordability in our market? Second, to give you an overview of the ways that we guide our thinking about which measures are ready for use in prime time, high stakes ways, like tiered networks, but also other accountability uses, including our provider-facing programs. And then finally, give you an overview of the way our tiered products have been designed and a little bit about what impact we've seen to this point. If someone could advance to the next slide for me. You should be looking at a picture that shows aligning provider and member incentives to make quality healthcare affordable. And so this is really illustrating that, in our view, there are three broad and interconnected pieces that we have to employ in order to both manage to a lower trend, but also achieve the twin goals that we have of improving quality and outcomes while at the same time reducing medical spending growth. We rely very heavily on provider engagement, and as many of you, if not all of you probably know, have led the country in a global budget-based model that we introduced in 2009 that now accounts for close to 90% of our provider network. That has done an enormous amount to align incentives on our provider side around generating better quality and outcomes while at the same time reducing medical spending growth. But it really tees up the importance of the member side of those incentives, and in particular, tools for members and product designs for members that will create incentives to be cost-conscious in how they choose care settings, and also to incentivize adherence to medical treatments. So I'll talk a little bit about a whole range of strategies that we use in that product design, but we'll focus on our tiered networks today. And then, of course, not to be overlooked is the third important strategy, which involves ongoingly attending to our own administrative expense and keeping that extremely low and affordable for our members, so that we're never having the administrative part exceed 10 cents on the dollar, and it's below that for our members now and has been for several years. So moving to the next slide. Here, what I'm illustrating for you is a framework that we use to guide our thinking about where the member-facing strategies for improving quality and outcomes and affordability fit in with our provider-facing strategies. And essentially, we consider that there are 4 broad ways that we as a health plan can use data, information, incentives, and reporting to try to improve quality and outcomes. The first of those is pictured by the yellow circle at the top, and that is simply reporting performance results to providers in our network with a relevant benchmark to try to motivate their attention to certain aspects of performance and their improvement. We can then attach financial incentives to those measures as we do in pay-for-performance programs, and that's pictured in the next circle to the right. And then we move to the member-facing incentives, including transparency or public reporting, where we attach reputations to the results of those measures. And finally, to where we attach market share to the results of those measures through tiered product design or limited network design, where the measures and results on those measures are used to determine member cost sharing. So you'll notice on the outside of those interlocking circles are red arrows that heat up as they go around, which really depict from the provider's perspective that these initiatives become higher and higher stakes as you move clockwise around this ring. And so the 3 that I named after reporting are all strategies that we regard as accountability uses of measures or high-stakes uses of measures. And the next slide illustrates for you that starting in January 2007, we have held ourselves to a set of criteria and principles that determine when a measure is ready to be used in any of those high-stakes ways. So ready to have financial incentives attached to it for our providers, ready for public reporting, ready for tiered or select networks. And while I won't take the time during this talk to go through in detail what's reflected on this page of principles, you have it to take away. What I'll highlight for you is that it really represents a blend of what we consider to be the art and science of good performance measurement. The science part reflected in a number of the features here that really point to important psychometric and statistical aspects of measures. The previous 2 speakers spoke a little bit about the importance of sample size, and we pay enormous attention to whether for each individual measure we have adequate sample size to get a stable, reliable piece of information about a provider's performance on that measure. And if we don't, we won't use the measure in the initiative, whether it's a pay-for-performance, public reporting, tiered network. And as you'll see as we get a little further into the slides, in the case of our tiered network design, we have a way of addressing tier placement for providers on whom we simply don't have enough information on any of the measures. But some of what's reflected on this page also isn't so statistical or scientific, but more the art of using measures in a way that will engage providers. This is, we view as a critically important part of the success factors of the ways that our measures to this point have been able to drive improvement both in our provider and our member-facing efforts. The next slide is a nice way to summarize 4 different types of strategies through which we can design products that incentivize various kinds of behaviors on the part of our members to pay attention to cost and quality. So in the top left is the category that we're spending our time on today, which is network design and product designs like tiered products that use cost differentials for the members to try to drive members to use the higher quality, lower cost providers. But just to highlight the other strategies, there is, of course, the use of high deductible plan design, which also in many ways is intended to influence members' choice of providers. But on the right-hand side, the set of strategies that's used less around choice of provider and more around adherence to various kinds of treatment recommendations or to the reduction of behavioral risk factors. So a good broad set of strategies is really important to have members really attending to all of these aspects: how much care to receive, where to receive it, and based on what the clinician's recommendations are, incentives to adhere to that advice. The next is a screenshot of our wellness portal and a view of just some of the ways that a member in our plan will be able to track progress on certain types of goals that they may have committed to. And this slide really is just a reminder of the importance of member tools as a complement to the incentives that we put in place. One of the important lessons learned for us around the introduction of tiered network products is that members really need to have education before they start to use that product about how to find the information they need about what providers are in the different tiers and what the cost differences will be, because a member who goes out and uses care before they understand the cost differentials associated with a tiered product design can be a quite unhappy member if they didn't understand that seeing certain providers comes with a higher price tag than seeing others. So doing proactive member outreach and having really clear tools available for members who are in products that do create these kind of financial incentives around different provider choices is, we have found, extremely important. On the next slide, I am just showing you how the enrollment in our tiered products has grown over time. The blue line shows the growth in our traditional options tiered product design. The red line shows after the introduction of what we call hospital choice cost sharing, how that has grown. Together, these two products, both of which really use a tiered product design, have about 230,000 members today. One thing that perhaps is worth underscoring is the important difference between a tiered product design and a narrow network design, with narrow networks being the kinds of networks that Sanjay and Nate were speaking about, is that in a tiered product design, the member has access to the full network. Every provider is in the network for them under their benefits, but the amount that they pay, the cost sharing that they pay, differs depending on which provider they choose to see. So just a few last slides to give you an overview of how our tiered product actually works. The next slide, which we'll move quickly over, but you can return back to, really is what was our vision as we were back in the early 2000s creating a tiered product. And you can see that it was to really use data to create meaningful financial incentives around differences in performance that were meaningful and important. The next slide gives you a sense of the kinds of measures that are used. These are the measures used on the hospital tiering that's in our options product. And what you might notice is that there's a broad set of measures that include both clinical process, meaning was evidence-based care followed, clinical outcomes. You can see some of the outcome measures over on the bottom right, mostly adverse events in hospitals that we would like to always see low rates on, and patient care experiences. They are reflected on the bottom left and captured through HCAHPS scores for our hospitals. A very similar construct with process, outcome, and patient experience is what we use to tier our primary care physician groups. We have no tiering that we do at the individual physician level because we have found that we simply don't have enough data to get a stable or reliable piece of information about individual doctor performance. So we tier physician groups and we tier hospitals as institutions. The next slide shows that we have 3 different levels of tier in our options product, and the most favorable is called enhanced, then standard, then the least favorable tier is called basic. And every provider in our methodology starts in the middle and either earns their way up to enhanced through having both high quality and low cost, or falls to the basic tier by having either high cost or poor quality. A provider for whom we have inadequate information on either or both will be in the middle tier, the standard tier, unless they do poorly on cost or quality, in which case they would drop down to basic. Finally, just to share with you what kinds of cost-sharing differences you might see in one of our plans. There are several different cost configurations at this point, but this will give you a sense of it. We have quite substantial cost differentials compared to some tiered products in our market and in others. For example, you can see looking down the column in the PPO product for the inpatient surgery that a member who chooses an enhanced tier hospital for that surgery would be paying $250, while a member who chose a basic tier hospital would be paying out of pocket $1,000. A very significant cost differential. While we aren't able here to report the results because they are under peer review, there is a formal evaluation of how the tiered product has worked in driving differences in members' choice of hospital. This has been led by researchers at Harvard Medical School and is under peer review and does show a very significant effect in the tiered product design in influencing which hospitals members receive non-urgent services. Emergency services, the cost differentials do not apply. So in summary, it's our view and our experience that a blend of member and provider-facing initiatives is extremely valuable to drive the goals of improving quality and outcomes while also reducing cost growth and contributing to affordability. Tiered product designs, as we've talked about, give members access to the full network, but begin to expose members to the differences in provider cost and quality. We use a very rigorous approach and methodology, and that has really helped us to avoid provider backlash against these products. Providers may not like the tiered products, though under payment reform, they've actually come to see them as a useful tool to help them steer members to lower cost, higher quality facilities. But even for those providers who don't like the idea of tiered products at all, they feel that the methodology that we're using is fair, and we haven't faced any of the criticisms, backlash, or legal action that some of our local competitors have seen. Since the introduction of the products, I shared with you the growth that we've seen in membership, and I did mention that there's a forthcoming evaluation that will show the significant impact that the products seem to have, at least on choice of hospital for elective procedures. So I'll stop there, and thank you very much for your attention.
Today I'll present a large employer's intervention to implement tiered physician networks and health plans, and what we learned about what happened based on observations of patient choices made through analysis of claims data. So this work was a collaboration with my colleague Meredith Rosenthal, and I want to acknowledge our grateful receipt of funding from the HICFO initiative at the Robert Wood Johnson Foundation for this work. So in terms of just a roadmap quickly for today, I'll talk a little bit about the networks themselves and then spend some time describing the Massachusetts Group Insurance Commission's Tiered Network Initiative, which is the setting that we evaluated, and then turn to the findings, what we observed, and finally conclude with some of the policy implications from the study. So I mean, a lot of this was covered very well by Dana in her talk just now, so I just want to highlight again here that this evaluation is looking at tiered provider networks, so these are distinct from narrow networks, and the idea here is for health plans to use managed care network design to try to channel patients to a preferred set of providers while maintaining their choice still, so that again all the providers are included in the network, and patients receive a quality signal, which is that patients or providers are tiered based on performance on quality metrics and efficiency, and also a financial incentive to choose a preferred provider, which is that in the case of physicians, they pay a lower copayment at the time of the visit than if they see a non-preferred provider. I'll refer to preferred providers also as Tier 1 providers. That's how they were named in the initiative that I studied. The middle tier, Tier 2, are average performers, and then finally the non-preferred providers were placed into a Tier 3. And so the idea is not only that there'll be an effect on patients, but that providers too will have an incentive as a result of this type of network design to change their own behavior in response to a loss of market share or the threat of a loss of market share that's associated with being in a non-preferred tier. Now turning to review how tiered networks affect patient incentives, essentially the idea is that the tiering aligns a patient's incentive to have high quality and high value care with their financial incentive to pay less out of pocket for their own care. The information about quality and value provided through a tier ranking could be useful to a patient, although it depends on their perception of the validity of the information and how it's presented, and also whether it provides new information. So do consumers trust the information on the quality that's coming from this particular source, and how does it help them based on what they already know? In terms of the literature, the evidence on patient response to quality information is mixed, and while patients are known to rely on recommendations from friends and family more frequently than formal sources of quality information, in part because they can be difficult to understand and use, there are studies that find evidence of changes in market share towards higher rated providers when rankings provide new information about provider quality. So when you think about the effect through the financial incentive, we have a lot of evidence that patients respond to higher prices in terms of cost sharing, and they switch away from care when it's more expensive to them. And in particular, in the case of prescription drugs, patients switch away when their own drugs get moved to higher and more expensive tiers, either to lower priced alternatives or they cut back on their care. But I think it's no surprise here to realize that physicians are very different than prescription drugs, and physicians aren't really considered to be interchangeable like drugs are, and the importance of trust between patient and physician suggests that copayment differences could be less effective to induce patient switching. There is early evidence that suggests consumer response to tiering in cases where the price difference across tiers is large. However, some of our own work on patients in Massachusetts who are in the plans that we're going to study on their awareness found low levels of awareness and use of the physician tiering, and this is also likely to affect our results. So turning now to the Massachusetts Group Insurance Commission's initiative. The Group Insurance Commission is a quasi-independent state agency in Massachusetts that's tasked with providing and administering health benefits to state employees, also employees of several local municipalities, and retirees and their dependents. And so currently there are over 400,000 lives enrolled in the GIC health plans. About 10 years ago, the GIC launched this initiative to create a database that could be used to construct tiered networks, and to do so, they worked with all 6 of their non-Medicare health plans and had the plans pool their entire books of business to maximize sample size and eliminate potentially confusing and conflicting measurement, and develop a database of physician performance at the individual physician level on cost efficiency and quality. The cost efficiency measures were case mix adjusted episode treatment, grouper evaluation of efficiency, and the quality measures were largely HEDIS-like claims-based process measures. So once this database was developed, the GIC gave it to their health plans and directed them to design a three-tiered physician network where physicians, very similar to the framework that Dana just presented, physicians were evaluated on quality first, and they needed to meet a quality bar in order to be placed into the top tier. And then if they also had low cost or a high cost efficiency, they would be placed in Tier 1. Average performers on cost were placed into Tier 2. This is also where physicians for whom there was not enough data were placed, and then the lowest performers were placed into Tier 3. The copayment differences across the tiers were for office visits and ranged from about $10 to $15 if you saw one of the preferred doctors, and went up by about $10 for each tier, so that about $25 for the middle tier and $35 at the top tier. Or I'm sorry, the bottom performing tier, the most expensive. When we looked at which types of physicians were included in these plans' tiered networks, the plans really focused on specialists, all 5 of the participating plans. We had to drop one of our 6 plans from our analysis due to small sample size and incomplete data. So in the 5 plans that we looked at, all 5 tiered these 6 specialties listed across the top of this slide. And then plans had flexibility to tier additional specialties, many of whom did. Some also chose to tier PCPs or internal medicine physicians, but many did not. And then while the GIC suggested that plans allocate about 20% of physicians into a top tier, 65 into the middle, and 15 into the bottom, you can see here that the actual networks constructed by the plans varied a little bit here. In particular, Plan 1 had a very large Tier 1, whereas Plan 5 put really the vast majority of physicians into their middle tier. So we were interested to the effect of tier rankings on patient choices, and in particular, whether we could observe whether a physician's tier ranking has an impact on a physician's market share of new patients versus whether there's any impact on the percent of a physician's patients who switch to see somebody else. We think these are different decisions that a patient makes, and tiering could have differential effects depending on which situation a patient is in. So for the first, on a physician's market share of new patient visits, what we did is we looked at all patients who had never seen a physician of a certain specialist type, nor had anyone in their family, and looked at the decisions that that group of patients made. And for the second analysis, for existing physician loyalty analysis, we looked at patients who had a relationship with a physician. So this is a patient who had at least 2 prior visits with a particular physician in the claims data in the prior 2 years, and then also returned to see a physician of the same specialist type once the tiered networks were implemented. And so among that group, the group of patients who was going back for another visit, we looked from a physician's perspective how many patients returned to see their existing physician versus how many switched away, and whether that varied by the existing physician's tiered ranking. So turning to the results, for the new patient visits, at the top of this chart, it shows you the predicted market share based on our analysis for doctors who had a top tier ranking versus an average tier ranking versus being in the bottom tier. And there's no difference for the top 2 categories, but those in the bottom tier had a predicted lower predicted market share of new patient visits than did their peers. While this number, 0.5, is very small, and there's a pretty small difference than in terms of the numerical value from the numbers above, 0.57. This is because we're measuring an individual physician's market share of the total pool of new patients in the GIC. And so for some specialists in a year, this was 800 or 900 patients. So while any one physician gets a very small number of these patients, when you compare the difference between a 0.5% of market share versus 0.57, it's actually a significant, meaningful difference from the physician's perspective. It's a difference of about 11% in terms of their own, in terms of the share of their share, essentially. It's a little confusing. I apologize. Looking at the specialists here, the second group of rows, we analyzed just specialist physicians. So we left out doctors who might be considered by a patient to be their usual physician. So internal medicine physicians, OBGYNs, and pediatricians, and again saw a similar pattern where physicians in the bottom tier had a lower market share of new patients than their peers. In contrast, among those usual care physicians, we found no effect, that there seemed to be no differential across physicians. And then turning to the question of whether there's any impact on patient decisions to switch away, we found the answer there to be no. We observed no effect of a physician's tier ranking on whether his or her patients returned for another visit or switched away. And this was also the case when we looked at specialists versus usual care physicians. So quickly, I want to reiterate that this is early evidence. This is in the first 2 years where this intervention was up and running, and so I think long-run implications will be important to evaluate to see whether these results change as patients learn more about the network design and become more familiar. I think it's also important that we study the impact of tiering on patient choices in other contexts, and in particular when hospitals are tiers. It sounds like the Blue Cross initiative will be out soon, so we'll learn something there. And also when there's a much larger financial penalty for patients depending on their choices across physicians than that was studied here, which was just a $10 to $20. So in conclusion, in contrast to what we observed among choice of prescription drugs, we do observe significant loyalty from patients to their physicians that they've seen previously. And also, I think interesting, we observe here that the impact of tiering on choices seems to be moving people away from the lowest performers as opposed to necessarily moving people from average up to the best performers. In terms of takeaways and implications, I think this makes sense. You know, from a patient's perspective, it may be that the type of information, the quality signal, and the financial incentive is more powerful when people are choosing to see a new doctor, which is more easy to trade off between seeing another new doctor, as opposed to switching away from somebody who you already know and have a relationship with and already have a set of impressions about. I also think that choice of health plan and provider is really complicated, and so while this evidence suggests tiered networks can be one element of this process, that education and other tools are going to be really important as we continue to try to understand how we can move market share towards higher value providers. And then lastly, I just want to highlight that the capacity constraints may also be important here, in which I mean by that is that at some point the top and most preferred providers are going to have full panels. It's going to be hard for patients to continue to move, in which case the provider response to these incentives is going to be pretty important. If providers themselves respond by improving their performance, then we could still benefit even if patients are limited by capacity in moving themselves. So thank you so much. That's what I've prepared for today, and I'm happy to take questions at the end.
Our final presentation today will highlight how reference pricing can also influence consumers to shop for value and ultimately lower prices and healthcare spending. And joining us to share his research on this topic is Dr. Jamie Robinson,
the Leonard D. Schaefer Professor of Health Economics and Director of the Berkeley Center for Health Technology at the University of California at Berkeley. He also has several other roles, one of which is serving as a member of NIHCM's advisory board, and we're so pleased to have him with us today. Jamie?
Thank you, and I'm certainly pleased to join you. I'm going to try to do two things with the group in the next 15 minutes or so. First is to talk about the interdependency of three strategies, if you will, that have been kicked around: price transparency, bundled pricing, and reference pricing. And really the context there is, why have these things been so unsuccessful in moderating costs, and what can be done about it going forward? And then secondly, I'm going to briefly present some evidence on effective reference pricing from a study we did in California, part of our ongoing work in California. Okay, so what, just start off with just the importance of pricing, and I actually think I'd like to define these first. First, reimbursement to me is that prices are set to cover costs. In other words, the buyers have to pay what the providers charge. That's the point of pricing. Whereas in purchasing, prices don't cover costs, they determine costs. It's up to the providers to develop services that the buyers are willing to buy at a price that they're willing to pay. And the larger context of healthcare payment is it's shifting from reimbursement to purchasing. And for this to be successful, prices need to have three characteristics. They need to be bundled and coherent. We don't want to buy car parts, we want to buy cars. They need to be transparent. We need to know what we're going to be charged before we make our choice. And thirdly, consumers, we need to care about prices. In other words, we need to have the perception that we're spending our own money rather than somebody else's money. Let's start with price transparency, which is, of course, right there next to motherhood and apple pie, close to the heart of all Americans. We all believe in price transparency. We believe in informed consumer choice. This gives incentives for the providers to compete on price as well as quality, creates pressure to reduce prices. We disclose everything on everything, why not prices? And also in their current moment of time with mobile technology, particularly smartphones, we have the ability now to have prices at the point of decision and prices that affect us. For example, I don't care the price charged by a particular doctor that I'm not going to go to. I don't care about the price charged by the doctor that I am going to go to who's being to somebody else, meaning someone else who's in a different insurance policy or someone else who's at a different point in their deductible. I really just care about what I would have to pay if I go there. And price transparency, of course, is coming. There's a lot of disclosure mandates around there, and this is one thing that the legislature seems to be very keen on. But let's just pause and just think a little bit on the challenges here. Making the current structure of prices, which are inscrutable and irrational, making them transparent is just going to reveal further how crazy things are up there. There's going to be some components of care which is simple enough that making the prices transparent is going to be okay. Like, laser eye surgery, or maybe a certain prescriptions. It's going to be just tell me what it's going to cost me and I'll make my choice. But most health services are consumed as part of an episode of care, and it's the episode price that really counts. When we go buy a car, we want to buy a car, we want to hear the price of the car, not the price of each of the components of the car. And so price transparency, if it's really going to be sensible, has to be accompanied by some kind of sensible bundling of the prices so that we know what the package of care that we're going to, and what's the price of that in provider A versus provider B, or product A versus product B. So now I want to move to bundle pricing. And I want to say, I and the Integrated Healthcare Association in California, we worked on this a lot. It has been very frustrating. This is where we start. Fragmented payment undermines incentives for everybody that's involved in healthcare to coordinate their activities and to improve efficiency. Moreover, the consumers can't act on all this fragmented prices, even if they were transparent. All sorts of good initiatives from Medicare and various private initiatives have really pioneered bundle payment for orthopedic surgery and a variety of other things, and it has been frustrating. This has been my experience. Well, first of all, the payers want savings from price bundling in the first year, but the providers want can maintain their income revenue streams because they need to invest in a lot of infrastructure, IT, a lot of work internally. And they will only embrace bundle payment if it leads, in their view, to gains of more patients, or at least to avoid losing the patients that they have. But most of the bundle payment initiatives to date have not had any form of consumer cost-sharing component. In other words, there's no incentive for the patient to use a provider that offers bundle pricing rather than non-bundle pricing. And so, frankly, my experience has been that out there in the real world, providers are not rushing to adopt bundle pricing. If they're mandated by Medicare, they'll do it. Otherwise, they don't either. And this takes us to cost sharing. Traditional forms of cost sharing don't influence consumer choice of really costly services. Annual deductibles typically target, by structure, low-cost preventive and primary care services, not high-cost specialty and hospital services, because those are all above the deductible. Coinsurance exposes the patient to only 20% or whatever the number is of the cost, and it's limited by an annual out-of-pocket maximum. So all co-payments charge the same price to the consumer regardless of the price charged by the provider, and typically small relative to the price of specialty services. Now, you can do tiered co-payments, and we've heard some nice discussion of those, but as a general, charging for someone $50 versus $150 for a hospital admission that's going to cost $20,000 is not really getting at the action. So reference pricing, which I'm going to talk about now, is one way of getting at that, and it's not the only way, but it's out there right. What is reference pricing? The reference pricing, the sponsor, by which you mean the employee, self-insured employee, or the insurer, establishes a maximum contribution, which is called a reference price, kind of a lousy term, but it's really a contribution that it will make towards the payment for a particular service or particular product. And this contribution limit is set as the minimum or the median of the range of prices charged by comparable providers in the comparable geographic market or therapeutic niche for like a drug. Then the patient must pay the full difference between the sponsor's contribution limit and the actual price that is paid to the provider, the negotiated price negotiated between the insurer and the provider. So the patient has to pay up, and the patient pays 100% of the difference, not co-insurance, not 20%, and that patient payment is not limited by some sort of out-of-pocket maximum. So in short, the patient has very good coverage for the options that are at or below the sponsor's reference price, but has full responsibility for payment for using services or products that charge prices above that. And to give a non-healthcare example, it's kind of like many of us travel on work, and our employer usually will have some sort of reference price on what a per diem we call it, on what we can spend on meals. My employer pays up to $72 a day for all in 3 meals plus miscellaneous. I can go to any restaurant I want, but they will pay up to $72, and after $72, 100% is out of my own pocket. There's no annual out-of-pocket maximum. It's not 20%. It's 100%, everything above 72, end of discussion. Okay, now what about the challenges to reference pricing? Of course, this is limited. Placing financial responsibility for price-conscious choice onto the consumer is inappropriate if the prices are confidential, they're unavailable, or just simply so complicated no one can understand them. Of course, consumers also need whatever is available in terms of quality data on outcomes, processes, et cetera, in order to compare price with performance. And we've made we in the U.S. put a lot of effort into collecting data on quality and satisfaction, and actually we have better data for that often than on price data. So this has gone full circle here, and then my point up to right now is that price transparency to work needs bundle pricing. Bundle pricing to work needs reference pricing, in other words, consumer incentives. And then reference pricing needs price transparency. So it's a circle. These three things are interdependent, and realistically, if we're going to make real progress, we have to make progress on all three of these. Now, I want to say a little bit more about what is reference pricing, a little bit of the evidence today. Reference pricing is best applied to products and services where there's a wide variation in price and the patients can, so to speak, shop. They have time to compare options, and it's been used most heavily for drugs in Europe, where the single-payer systems, they set up a particular price within a therapeutic category for what they'll pay for a type of drug, and the patient has to pay anything above that reference price the patient pays. It's been applied to laboratory tests and diagnostic imaging, such as MRI, CT, here in the States. It's been applied to scheduled non-emergency surgery here, both inpatient and ambulatory. The purchasers in the States are increasingly concerned, as you know, with hospital consolidation and the effect of that on prices, and also to the indifference of consumers to prices. And the traditional managed care strategy of bargaining low prices with providers really doesn't seem to be working very well anymore because the providers are consolidated. There's inadequate supply of many specialties in many markets, and prices simply are going up. There's a study that we did in California. Reference pricing was pioneered by CalPERS. CalPERS is the public employees retirement system in California. It offers health insurance as well as pensions to about 1.3 million Californians, employees, dependents, and retirees of the state and other public entities like school districts. About 450,000 of those are in self-insured PPO, the remainder being in a couple of HMO options. This discussion is all about PPO. And it saw in its data that it was paying about between $20,000 and $120,000 for the same procedures, in other words, hip and knee replacement procedures in different hospitals across the state without any evidence that the higher prices were associated with higher quality. A few years ago, as you know, the state of California almost went bankrupt. There was very little sympathy out there for this kind of behavior. And the CalPERS had to moderate its rate of expenditure growth, and it was either going to do reference pricing or it was going to move everybody to high deductible health plans. It's heavily unionized workforce. The unions chose reference pricing over high deductible. They chose, they set this rate at $30,000, which got about 50 hospitals, charged less than 30,000, were nicely geographically dispersed across the state and scored as well as or better than the average in terms of the Blue Cross Blue Shield quality metrics on orthopedic surgery. And PERS then initiated an employee communication strategy, a very elementary transparency strategy, which basically was one of, here's the list of the hospitals we suggest you go to. If you want to go to the other hospitals, you can, but you're going to pay more yourself. I just want to contrast this, by the way, to a narrow network strategy. Reference pricing is a broad network strategy. It is not that you can go to any hospital, but you're going to pay more if you go, and how much more depends on how much they charge. So it's really up to the hospital how much they want to charge you, and you're the consumer. You get to pick which hospital. The hospital gets to choose what it's going to charge. We're not controlling either of those things, but we, PERS, are controlling how much we will pay. This is just a graphic. This is the range of prices for knee and hip that they were charging. Each of these little bars is a hospital. So it's the average price charged to CalPERS. These are 2009 data prior to reference pricing. You just see this range of incredible range for, it's really a pretty commodity surgical procedure, knee and hip replacement, scheduled, non-emergency. So what happened? At the beginning of 2010, they put in reference pricing, and what you see, this is what happened. This is choice of hospital. The red lines are the CalPERS data, and the blue lines, we had a control group of Anthem, Blue Cross, PPO enrollees who are not subject to reference pricing. And the dotted lines are the market shares of the lower cost hospitals, called value-based purchasing design hospitals. It's a great CalPERS euphemism, meaning low price. And the solid lines are the high price. And the punchline is on the red line, the solid red line goes down very significantly after January 2010, and the dotted one goes up. Whereas for the Anthem people not subject to reference pricing, there's not any change. Nothing's happening in particular out there in the market. They're just doing their thing. So that's, first of all, a change in market share towards lower-priced hospitals. Frankly, this is a little bit surprising to me because I was impressed that the market share of the high-priced hospitals didn't go to zero, given patients would be at risk for paying very meaningful out-of-pocket sums. But this is what happened to the prices. Next slide is this one. This is the price charged to PERS before and after reference pricing. Remember, again, the red lines are the PERS, and the blue lines are the control group. And what you see is that prior to reference pricing, prices were going up. This is America. Prices go up in healthcare. But then after reference pricing, for the PERS, there was a very significant reduction in the average price. What it was about half of the hospitals that were high priced, above $30,000, made very meaningful reductions in their prices. The other half just let the patients go. And there was no big effect in any other in the control group. And so it's this reduction in prices that really maintained the market share for the formerly high-priced hospitals. They really faced a classic trade-off of do we want to have a high price, low volume, or lower price, higher volume. And different hospitals pursued different strategies, and this was the big effect. The big trend. And the effect on PERS was really as follows. The reference pricing did induce enrollees to disproportionately shift to lower priced facilities compared to pre-reference pricing, but the bigger effect actually was on hospital prices. PERS saved $6 million in 2 years just from this particular procedure. It's now extending reference pricing to ambulatory surgical facilities. We're in the midst of study of that. Other services, reference pricing is likely to affect consumer choice, but probably not the prices. We're doing a study with Safeway on lab and imaging. And what's striking about these is that we had really elementary transparency, but transparency tools are dramatically improving out there now. Safeway, PERS, others now working with various different kinds of specialty tech firms on transparency strategies. And here is, down at the bottom, is the Health Affairs paper if you're interested in more details of the study. So I'm going to wrap up here, and not to say that any of this is a panacea for anything. The limits of price transparency, but it's very limited, but it does support patients as shoppers, and it's consistent with our larger culture of sunshine and Facebook. But to really transform healthcare, price transparency requires some form of bundle payment, coherent payment, and reference pricing. Secondly, bundle pricing is a good thing. It gives incentives to doctors and hospitals to work together. That's its great virtue for efficiency and cost reduction. And it allows the payers to compare price with performance. We can have a little bit of a sensible trade-off there. But to transform healthcare, it really requires some sort of reference pricing or some sort of consumer incentives so that the consumers choose those hospitals, and also transparency so they can really understand those. And finally, the limits of reference pricing. It does help convert patients into shoppers. It does help stimulate price competition among providers. But if it's really going to be extended, it does require more transparency of prices and more coherent prices for complicated procedures as we move beyond fairly simple things like joint replacement and lab imaging. So we move into more complex chronic care. It would require more and more bundling of services. So I want to leave it at that and say thank you.
Thanks so much, Jamie, and we look forward to your continued research and thinking on reference pricing as it continues to be discussed and debated as a cost control and consumer engagement strategy. We're excited to now spend our last 15 minutes or so together engaging with our audience of healthcare decision makers from policy, business, and government. And at this time, I'm going to ask our operator to explain how you can ask a question if you're joining us by phone today.
Thank you very much. Ladies and gentlemen, if you would like to ask a question, please signal by pressing *1 on your telephone keypad. If you are using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. If you have signaled for a question prior to hearing these instructions on today's call, please repeat the process now by pressing *1 again. We'll pause for just a moment to allow everyone an opportunity to signal for questions.
Thank you. While we're waiting, we'll take some of the questions that have come in on the web, and if you're just listening through the computer, you can continue to type in your questions. We'll try to get to them time permitting. One question, and I think this is for Dana, is how does a member know that they're choosing an enhanced tier provider? And you mentioned some of your member-facing tools. What if the provider drops from enhanced to standard during the course of a treatment? Is the member consumer penalized with higher copays?
Great questions. So let me answer the second one first. No, changes in the tier placement as we update the data underlying our tiering do not affect members until a renewal of their benefits, at which point they would know how the tiered product works and any changes that happened. And how they get that information is a combination of online tools and also paper materials that tell them about the providers that they're using and as well as our whole network of providers and which tiers they fall into, and for their product design, what the cost implications of that are.
Great, thank you. Yana, do we have any questions on the phone?
There are no questions on the phone lines at the moment. Ladies and gentlemen, as a reminder, if you would like to ask a question, it is *1 on your telephone.
Great. Another question from our first presentation for Sanjay and me is, how would one decide what products and networks are valued by consumers? I think you touched on the differences in geography, and this person is saying what is essential to one consumer may not have value to another. And could you talk a little bit, expanding on your research from the consumer perspective?
Sure, and this is Nate. I can speak a little bit to that. I think, not to be pedantic, but the most important question is, as we talked about, or the most important thing to do is really just to dig in and ask the consumers and start with good fundamentally grounded research to see what the dynamics are. What we ultimately found at the end of the day is that, in most markets you see a pretty discrete set of segments emerge in terms of the preferences of your potential member population. And while there may certainly be, for example, managed care is probably the simple factor to pick, the preference and comfort level for managed care and tighter systems is much stronger in some parts of the country versus others. Within any population, even when you overlay those trends, you'll start to see kind of clear segments that pop out from the population. And anytime you're talking about trade-offs like this, it will never be possible to design products or networks that absolutely delight 100% of the population. That type of an aim is never possible, but there's definitely a trade-off that emerges as you start to go through these exercises in terms of seeing the products and networks designed that can delight a good majority of the people that are out there, and then also making some decisions as an organization in terms of if there are some distinct dividing lines or segments within the populations, are there ones where it's better for us to simply pick a side and say we're the type of hospital payer health system that is better equipped to go after segment A of the population, and then our competitors or our partners down the road are actually better off going after segment B.
Great, thank you. A second question for Nate and Sanjay. A member of our audience asked, what can providers do to appeal to these narrow networks? And I think she might mean both how do providers make a narrow network appealing, and also how do they appeal themselves or make themselves valuable to be included in the network?
So I'll go ahead and take this. This is Sanjay. It's such an excellent question. We've spent time doing similar research with health systems on this very topic. I think for the first time in a long time, systems are recognizing that the need to appeal to consumers, it goes beyond branding efforts, your traditional elements of sprucing up your facilities, better food, better access, friendlier care. So a couple of things that we've found in our work have been helpful. I think firstly, as Jamie talked about, a number of providers are working toward creating greater transparency and bundling around the set of services that they offer, and we believe that that's going to be an important place and an opportunity for distinction. The second thing we're seeing with a lot of providers is a willingness to accept and promote some of the metrics that they have around patient experience, satisfaction, and whatever quality measures they have. So putting those metrics out there, holding them out so that folks can see them as part of the decision-making criteria, and then continuing to work against that frame as opposed to perhaps shielding them from public consumption, recognizing that's the culture in which we now live in with consumers and patients. And I think the last one is important is a number of health systems are recognizing that increasingly, just like in other industries, being differentiated and having a point of distinction with consumers is becoming more important for many of them. So not trying to be all things to all people, understanding who are their target patient segments, what are the service areas or areas of distinction, centers of excellence and the like, where they'd like to be known, and really using those to differentiate themselves in the market and attract particular segments of the population.
Thank you. A question for Jamie. You mentioned that in your work that reference pricing should only really be used or applied to certain procedures, and more price transparency is needed. How would you respond to some of the recent attention given to reference pricing and its ability to be used by large employers and self-insured plans? How would you respond to some of the concerns that it might be abused at the consumer's expense, and how do you think it will be used going forward as a tool or strategy?
The one set of criticisms that apparently out there are that reference pricing will unduly limit the choices facing the consumer because realistically they can't go to the high-priced providers and all of that. And there's obviously some truth to that. If this could be a very high out-of-pocket for the consumer, it's not really a realistic choice. But I think this needs to be put in context of we're in an era of the great popular innovation right now is the narrow network product. And reference pricing is a choice-maintaining strategy compared to narrow network, which is inherently a choice-limiting strategy. And you want to think about narrow network is reference pricing, but where the employer doesn't pay up to the reference price, the employer pays zero for providers that are not preferred. So reference pricing has got to be better than that from a choice perspective. Now, so anyway, that's one. Another critique is that, well, this is all, consumers don't have good information on pricing. How can they make intelligent choices? And I don't know what to say about that except yes, this has got to be done as part of the gradual evolution of the system towards greater transparency on prices. And it's underlying it is a general worldview, which is that consumers need to think about healthcare the way they think about other major important decisions, like, I don't know, which college to pick for your child or as the child for himself. That's a big, important decision, and it involves price as well as quality, and somehow we think that parents and young people should make those choices kind of for themselves, and that the government shouldn't make that choice for them and kind of assign them to universities. And ditto in healthcare, we want to enhance the ability to make healthcare choices for themselves, but those choices need to take price as well as quality into account, and reference pricing is part of that. Like I say, it's not a panacea. There's good parts of healthcare which are not good candidates for reference pricing, and there's roles for other kinds of cost sharing, and there's roles for regulation and for the health plans as a negotiator on behalf of the consumer. But my experience being around health policy for decades now is that revolution from above doesn't work in America. Trying to have the government transform the healthcare system gives us a backlash against Obamacare and against government regulation. Trying to have the insurance companies do it gives us a backlash against managed care and insurance companies. The only way that we're going to have a more affordable healthcare system is if the average American believes that lower costs in healthcare save money for that person, so that my choice is to save money for myself and not just for some employer, insurer, or government or something like that. And reference pricing, or cost sharing more generally, is part of that movement.
Thanks, Jamie. I had you just touched on a little bit of the ACA and sort of the influence on insurance changes and prices. And there was an audience question more for Dana and Anna about how the Massachusetts healthcare reform and the ACA ultimately influenced the tiered plan creation in Massachusetts and what has been the impact on cost to date. Maybe to inform people that are thinking about this in other parts of the country.
Oh, well, I guess I would have to say that at this point that our tiered product, as I described it to you, was introduced well before the ACA was passed or even drafted, and really hasn't been changed or redesigned. So I think that the ACA's introduction, if I understand the question, really is extremely important, of course, but with respect to the way that our tiered product is designed or needs to be designed, really is not something that's had an impact or that we see having an impact. Hope that answers the question.
Yeah, and I would just add that I think, at least here in Massachusetts, there has been a fair amount of influence from the state policymakers on the topic of tiered and limited networks. It's been a part of some of the state level cost control legislation that's been passed over the last few years. And so while we don't know yet we can't really say yet their impact on overall costs, it is, I think that's part of the reason we've seen more activity here in Massachusetts from the health plans on these types of products than perhaps in other places in the country.
Great, thank you. We are at the 2:30 mark. I don't think, Jana, are there any questions that have come up?
No, Ms. Centura, there are no questions on the phone lines.
Great, thank you. We've tried to address the questions that came through online. If we didn't get to your question, I apologize, but I'm sure that our speakers would be happy to try to help you get more information, and you can feel free to contact us as well. I do want to thank our panel of speakers for taking time from their schedules to join us today. We heard a lot of really interesting information, and we'd love to get feedback from our audience on this event. And we also encourage you to look out for future webinars in our Driving Value series. So thank you all again for joining us today. We will have an archive of the event, and we'll send that out to all of you, and you can also access the presentations online. That concludes our event today. Thank you so much.